Great. Hi, everyone. My name is Sarah Yip, and I'm going to be presenting some machine learning data related to real-world clinical outcomes. So specifically, this is using Connectome-based predictive modeling to, as I said, predict a real-world clinical outcome, in this case, abstinence from cocaine and from opiates. So I often get asked why even use neuroimaging data to predict treatment outcomes in the first place. So we're pretty lucky in the addiction field. We have a large number of evidence-based treatments that are really very effective for some individuals. However, we also have a lot of between-patient heterogeneity, which unfortunately means that the overall efficacy of any given treatment tends to be highly variable across individuals. And so given that heterogeneity, it's perhaps not surprising that even gold standard treatments tend to have high rates of relapse, and that most individuals with a substance use disorder go through multiple failed treatment attempts. So in other words, when it comes to addiction treatment, one size really doesn't fit all. Relapse rates following treatment also remain high. So even if someone's abstinent during treatment, relapse after treatment is very common. And for some substances, such as opiates, this is actually a really critical vulnerability period for opiate-associated death. And this problem is really further exacerbated by the fact that what I like to call traditional clinical variables, so for example, baseline severity, don't tend to be all that helpful for predicting outcomes, meaning that we have these unexplained sources of variance that are contributing to this heterogeneity in treatment response. So within that context, a number of researchers have really turned to neuroimaging measures to try to identify brain-based predictors of treatment outcomes. So over the past 10 to 15 years, there have been a number of sort of proof of concept studies linking brain function and structure to treatment outcomes in addiction. So for example, work by our group and others indicate that individual differences in pretreatment reward-related activations are prospectively linked to within treatment abstinence, that changes in functional neural circuitry may co-occur with reductions in substance use, and that individual differences in functional connectivity relate to both current cocaine use and future cocaine use. So collectively, data from these and other studies are really supporting this overarching hypothesis that individual differences in brain function are indeed linked to individual differences in treatment outcomes. However, this work, including my own work, also has some limitations, including relatively small sample sizes. So for most studies, we're really talking about n's on the order of like 20 to 30 per group, because it's really complicated to do a neuroimaging study where you're scanning people prior to treatment and then really following them appropriately throughout the whole course of the treatment and after treatment. So it's partly, the small n's are partly just a reflexity of the sheer complexity of this kind of research, which I'll return to a bit at the end of my talk. But in addition, other limitations are that most prior studies, other than what I'm going to be showing you today, really hadn't used methods that are recommended to avoid overfitting, such as cross-validation, leading to inflated effect size estimates, and decreasing the likelihood of replication in other samples. Finally, with one or two exceptions, the overwhelming majority of prior work in this area had been activation-based, meaning that it had focused on voxel-wise changes in bold signal, but typically had not assessed neural activity at the network level. And even among those studies that had used network-based approaches, they'd typically done so using approaches that ultimately require some sort of a priori selection of networks, and therefore that are not truly data-driven. Machine learning approaches, of course, seek to reduce overfitting via creation of a predictive model in a data-driven manner using a training data set and application of that model to a testing data set, which is used for model validation. For me, that distinction is really important because whereas the aim of traditional statistical approaches is, of course, to explain the variance between the relationship between two variables, the goal of machine learning is just to generate novel predictions in novel data. And so I would argue that that type of approach is really critical for the eventual translation of research findings into clinical settings, which for me is really the primary challenge of modern psychiatry. So we have all this great research, but we're not able to really take it into the clinic. In addition, if used appropriately, I would argue that these approaches can really be used to advance neurobiological discovery, which for me is important because so for me, in addition to generating predictions in novel data, a primary goal of brain-based clinical modeling really needs to be elucidation of mechanism because as we know, even highly predictive models often do little to advance our mechanistic understanding. So throughout this talk, I'm really going to be focusing on ways of trying to maximize neurobiological discovery within the context of predictive modeling. Which brings me to the first data set that I'll be talking about today. So the study design for this is pretty simple. We recruited patients entering a 12-week treatment trial for cocaine use disorder, scanned them before treatment and then again after treatment. all of our patients were receiving methadone maintenance for opiate use disorder, but were now seeking treatment for cocaine use disorder. So these are polysubstance using individuals. I'm not going to talk about the specific aspects of the RCT today, but if people are interested, this was a randomized trial of behavioral therapy with or without treatment with the cholinesterase inhibitor galantamine. And if you're interested, the results are published in the Journal of Clinical Psychiatry. So consistent with the overall RCT, our neuroimaging sample here was predominantly male. They were mostly unemployed. The primary route of cocaine administration was via smoking. And most individuals had a number of prior failed treatment attempts. So an average of 3 prior outpatient treatment attempts, an average of 3 prior failed inpatient treatment attempts, and a lot of significant legal problems. So this is a very treatment refractory population, but it's really not very unusual. The machine learning approach that we're going to use today is also pretty straightforward. So this was developed by colleagues at Yale and is referred to as Connectome-based predictive modeling. Unlike some other machine learning approaches, this is an entirely data-driven technique. It doesn't require any a priori specification of networks or regions of interest, meaning that it's both a predictive tool and a method of identifying networks observing specific behaviors. And it's previously been used to predict a range of trait-level behaviors, such as IQ, but it hadn't been used previously to predict an actual clinical outcome. So when we use this approach, our input is just connectivity matrices from structural or functional data. More specifically, when we use this approach, we tend to use connectivity matrices generated from task-based data as opposed to resting state data. People often get hung up on the notion of using task-based data because, of course, connectivity analyses have traditionally focused on resting state. However, some really excellent work by colleagues at Yale has demonstrated that actually the accuracy of brain behavior models generated from connectomes that were computed using task-based data tends to outperform that of models using connectomes from resting state data. So here on your right, you have the accuracy of models generated using resting state data from the Human Connectome Project at the top and the Philadelphia Neurodevelopmental Cohort at the bottom. And you can see that the resting state models have lower predictive accuracy. And also, if you look on the left, this is just summarizing the variance explained by each model. And so task is on the far right for each of those bar graphs. You can see that not only does rest not perform as well as task, but that the predictive accuracy of different tasks differs for a given behavior, suggesting that perhaps brain state might matter when it comes to prediction, which is something I'll sort of come back to. So for this study, we had a couple of different types of functional data to choose from. So during pre-treatment scanning, everyone did a reward task, and they also did a cognitive control task paradigm. And so when we were trying to figure out how to analyze these data, we kind of just went with the reward task because we were interested in cocaine use and dopamine, and there was kind of a consistent literature there. This is really a pretty simple reward task in which participants are presented with a cue indicating an amount of money to be won or lost, followed by a delay. Then there's the presentation of a target to which the participant responds with a simple button press. And finally, the participant is provided with feedback about the outcome of the trial. So using the data acquired during this, we computed our individual participant functional connectivity matrices. And we're feeding this into our model along with our measure of within treatment abstinence, which here we're defining as the percentage of bi-weekly urine specimens or negative for cocaine during 12-week treatment. So this is a biologically verified dimensional measure of abstinence. It's not just yes/no abstinence, it's percent of abstinence during treatment. So practically, when we take this approach, what we're doing is we're just taking, as I said, the individual connectomes from a training data set, and we're relating them to our behavioral variable of interest, in this case within treatment abstinence, and we're doing that using correlation. And doing this, we can identify positive predictive edges, so connections for which increased connectivity is positively associated with the behavior of interest, and negative predictive edges, so edges for which decreased connectivity is associated with the behavior of interest. So this is our feature selection phase. We then just create simple summary scores by summing all of the edge weights for the edges identified as positive features and for negative features separately. We then generate our brain behavior model by entering these into simple linear models, so y equals mx plus b, to generate a brain behavior model of abstinence. You can do it in a nonlinear manner. Here I'm doing it in a linear manner. So then we have our model, and what we then do is we take our testing data set and we extract edge weights from those edges we identified in our feature selection phase in the training data set. We again do this really simple summing where we're just creating a summary score for positive and negative edge weights. We apply the model we just generated, and we use that to generate individual predictions of treatment response. And then, of course, we have to compare the accuracy of our model, so we compare predicted treatment values versus actual treatment values. We can do that a couple of different ways. One really simple one is just rank correlation, which is what we're using here. So here on the y-axis, we have individual participant abstinence values as predicted by our brain behavior model. And on the x-axis, we have actual abstinence values for each participant. Typically, when we use correlation, we're looking at the relationship between two variables. Here, we're just using it to characterize predictive accuracy, so the correspondence between actual and predicted. We can see that we have relatively good accuracy. So we have a Spearman zero of 0.42, which means that about 20% of the variance within treatment abstinence is accounted for by connectivity within these networks. And interestingly, that correspondence is much higher than if we just relate abstinence to other clinical variables, including baseline cocaine use. And we've done that using things like SVR and all of that, and throwing multiple predictors in. And in this particular data set, the brain really does predict better than a combination of the clinical variables, though that's not always the case. Very importantly for me, in addition to generating predictions, this approach also, as I mentioned, identifies connections. So before I show you the brain networks, though, I just want to remind people that networks generated using connectome-based approaches are typically complex and can span multiple adjacent and non-adjacent brain regions. So here on the left, we have our positive network shown in red. As a reminder, this is the network that includes connections for which increased connectivity predicts abstinence. And on the right, we have our negative network. This is a network for which decreased connectivity predicts abstinence. And so while these networks are complex, and in my opinion, certainly difficult to interpret when presented in this fashion, it's important to point out that the total number of connections between these two combined is only about 500, which is less than 2% of all possible connections using this parcellation scheme. So despite this visual complexity, these are really quite specific connections. So there are a number of standard ways that we can start to summarize these connections to facilitate interpretation, which again for me is a key goal of prediction. One incredibly simple way of characterizing our networks is to just summarize them via connection distance. So for each nodal connection, we can just compute Euclidean distance using centroid coordinates for each node. If we apply this to our networks, what we find is that both networks include both short and long-range connections, but the positive network is characterized by predominantly more longer-range connections, and the negative network has predominantly more shorter-range connections, which just makes intuitive sense because longer-range connections tend to be involved in higher-order processes. Another way we can start to summarize our networks is, of course, anatomically. So these circle plots are summarizing network connectivity based on the number of connections between macroscale brain regions, and they're represented in rough anatomical order. So lines coming from these red bits at the top correspond to connections coming from prefrontal cortical regions, and lines coming from the purple bits at the bottom correspond to connections coming from the brainstem. And then from left to right, we have connectivity threshold across different levels. And you can see that if we sort of use a liberal threshold, for example, if we look only at the brain regions with 5 or more edges, our networks remain somewhat complex. However, as we start to use a more conservative threshold, they become a bit more interpretable. So for example, we can see that the positive abstinence network, which is shown in red at the top, is characterized by a really high degree prefrontal node that has connections to temporal, limbic, and other prefrontal cortical regions. And similarly, we can see that the negative network at the bottom has this really high degree temporal node with connections to limbic and cerebellar regions. Another good way of sort of summarizing these networks in terms of anatomy is just via their spatial overlap with canonical neural networks. So, overlap with frontal parietal, salience, default mode, et cetera. When we do this, we can then characterize the connectivity based on the number of connections between these established networks. So here we have matrices summarizing overlap for the positive and negative networks separately. For each matrix, the cells represent the total number of connections within and between each network, with darker colors indicating a greater number of connections. So we can see that the positive network is characterized by a large number of frontal parietal and medial frontal connections. as represented by these dark red squares. And we can also see that the negative network includes a large number of salients, default mode, and medial frontal connections. And these differences become even more apparent if we directly compare the number of connections within each network. So we can see that the positive network includes more frontoparietal, medial frontal connections, and more salient subcortical motor sensory connections. In contrast, the negative network includes more connections between the medial frontal network and salients and default mode connections. And so based on these differences, we've generated a theoretical network-based model of cocaine abstinence. So based on these data, we propose that cocaine abstinence is positively predicted by increased connectivity within and between frontoparietal and medial frontal networks. So as a reminder, these are networks that are involved in coordination of attention and executive control mechanisms. And we think these might be related to treatment via coordination of top-down processes necessary for treatment engagement. So like acquisition of new skills and enhanced control over impulsive behaviors. Our data further suggests that abstinence from cocaine is positively predicted by increased connectivity within salient, subcortical, and motor sensory regions. These are networks involved in salience encoding and reward, and we think that they might support motivational processes relevant to treatment. So like willingness to change and shoring up of non-drug reward processing and attending to alternate rewards, things like that. Finally, our data indicate that abstinence is further predicted by decreased connectivity between these two systems. And so based on prior connectivity work in cocaine disorder, we think that basically appropriate separation between these two systems might relate to greater behavioral flexibility or decreased compulsivity, as might be required for behavioral change during treatment. So this model is really building very heavily on prior models of addiction, emphasizing separation of frontoparietal and salience networks, but it's also now incorporating motor sensory and subcortical networks as well. And really, the reason that we're sort of summarizing things in this theoretical manner is because we really want to encourage future research. So our hope is by proposing this framework, we're going to encourage others to test these hypotheses in their own data. We've also released, the actual networks themselves, but sometimes having like a theoretical framework for understanding complex networks can be really helpful. And the last thing I want to point out on this slide is that even though we didn't model specific events of interest, if you remember, this was, I've identified this network using reward task data. And actually, this sort of working model is actually kind of interpretable within the context of that task performance because it requires coordination of both attentional and cognitive control processes as well as salience and reward responding, right? So it's possible that brain state may in fact matter for prediction. We've also tested the ability of the identified networks to predict abstinence following treatment. So for these analyses, we've just analyzed data from post-treatment scans. Here our sample size is a bit smaller. We only had about 40 individuals post-treatment. And we're just using the networks we identified in the pre-treatment data and extracting connectivity strength and then entering that, relating that to abstinence during 6-month follow-up. And we find that post-treatment network strengths were in fact significantly correlated with post-treatment abstinence, suggesting relative consistency of this relationship over time. Further consistent with that, when we just compare pre versus post-treatment connectivity strength, we don't see any changes over time. So the big question, though, isn't really whether or not these effects are stable over time. It's whether or not these replicate in an independent sample. So all of the analyses I've shown you up till now were done using a leave one out cross-validation scheme where we're just taking a single participant's predicted value, or we're computing each single participant's value, the left out participant, by taking data from everyone else as training data and doing that in an iterative manner. However, that can definitely overfit the data, so we wanted to have an external replication sample, which is no small feat because, again, clinical neuroimaging data, especially in addiction, is kind of hard to come by. So we did manage to cobble together a replication sample, the exact details of which I'm not going to go into too much today, but basically it was 45 individuals who were seeking treatment for cocaine use disorder. About a third of them were also taking methadone, as in our original sample, but 2/3 of them were only cocaine dependent, so they weren't polysubstance users and they weren't taking methadone, and were scanned prior to a totally different treatment involving a totally different medication. So this is definitely a heterogeneous replication sample. And for a replication sample, we're again just taking the masks we already identified and using them to extract connectivity and entering them into correlational analyses with our biological measure of abstinence, which is % cocaine-free urines. And in fact, we find the same relationship between network strength and within treatment abstinence in this heterogeneous independent sample. So for me, this is believable. So in addition to looking into external replication, or to doing external replication, we've also been looking into the specificity of our networks across drugs as well as across tasks. This is data that's impressed at molecular psychiatry and was led by Sarah Lichtenstein, who's a really awesome postdoc in my lab. For these analyses, instead of focusing on cocaine use, we're now focusing on opiate use. However, the primary sample is the same. So if you recall from the beginning of the talk, when I introduced our sample, I mentioned that despite seeking treatment for cocaine use disorder, everyone was currently methadone maintained. And in fact, there was a fair amount of non-methadone opiate use in this sample over the 12-week treatment. So the clinical rationale for really, for looking at sort of separate mechanisms of cocaine versus opiate use came from some EMA work done by Epstein and colleagues a few years ago, back when JAMA was still archives. This was an electronic diary study of 114 methadone-treated individuals that also had cocaine and opiate dependence, so very similar to our imaging sample. And what they did was they asked participants to track changes in mood and craving, as well as substance use. And what they found was a differential association between positive versus negative mood states and future substance use, such that cocaine use was most robustly associated with having been exposed to the drug or being in a positive mood state, suggesting links with impulsivity or reward. But that heroin craving was most robustly associated with increases in negative affect, suggesting possible links with emotion regulation or inhibitory control. So based on this finding that different mood states predict differentially predict opiate versus cocaine use, even in the same individuals, we wanted to know if different brain states might differentially predict those two behaviors. So for these analyses, we're just generating our connectomes from cognitive task data. This is a standard Stroop task. I'm sure everyone is familiar, so I'll just sort of skip over that. So we compute our connectomes from this Stroop task data, and we're feeding it into an independent CPM to try to predict opiate abstinence during the treatment, again, using a dimensional biological measure, so results of biweekly urine testing over a 12-week treatment. And here again on the y-axis, we have individual participant abstinence values as predicted by our brain behavior model. And on the x-axis, we have actual abstinence values. And we can see that there's a fair correspondence between actual and predicted values. So the Spearman's rho is about 0.34, which means that roughly maybe 12% of the variance and within treatment opiate use is accounted for by connectivity within this network. As with our cocaine network, the opiate network we identified as complex and includes connections between multiple adjacent and non-adjacent brain regions. In fact, this network is somewhat larger than the cocaine network, so it has about 1,000 edges, so it's almost twice as big. But even though it's almost twice as big, it's still less than 3% of all possible connections. So again, these are quite specific connections. We need to come up with better ways of visualizing them because this just looks ridiculous. So because we're interested in mechanism in my lab, we were of course really interested in looking at the anatomical overlap between the opiate and the cocaine network. So now we have our circle plots again, and we're just showing edges that were consistent between the cocaine and the opiate network. And as you can see, there's only 8 of them, 5 positive ones and 3 negative ones. I won't go into their anatomy at the moment. And then we also identify 11 edges that are, even more edges that are actually opposing. So these are edges for which, for example, increased connectivity positively predicts cocaine use, but decreased connectivity positively predicts opiate use. So these are connections that have completely opposite relationships, even though these networks are derived in the same individuals. Overall, there's very little overlap, and the overlap that does exist, more of it is kind of in the opposite direction. So these are really suggesting kind of dissociable neural substrates of opiate versus cocaine use. To begin to understand the anatomy of our opiate network, we can again summarize them via overlap with canonical networks. When we do this, we can see that at least relative to the cocaine network, the opiate network is actually more sparse. So the cocaine network had basically had within network connections for every canonical network that we looked at, but the opiate network doesn't have that. So even though it's larger, it has overlap with fewer different canonical networks. When we directly compare our positive versus negative networks, we can see that the positive network includes relatively more within network connections of the motor sensory networks, whereas the negative network is characterized by more connections between motor sensory, frontal parietal, default mode, and medial frontal networks. We were a little bit surprised by the large number of motor sensory connections here, although there is an emerging literature really emphasizing the centrality of the motor system for impulsive behaviors and for some types of substance use. But we were wondering about the centrality of this. So when we took a virtual lesion approach where we're just like knocking out all connections related to the motor sensory system, and we find that even when we do that, the remaining connections still predict. And similarly, if we knock out other canonical networks, so for example, we don't have any within network default mode, but if we knock out all connections between the default mode and other networks, our model still predicts. Suggesting that really no one canonical network component of this is alone necessary for maintenance of abstinence. To facilitate understanding, we've again proposed a theoretical model that summarizes key aspects of this network. This figure just emphasizes that abstinence was associated with increased within network connectivity between motor sensory and increased motor sensory connectivity and increased between network connectivity of motor sensory, salience, default mode, and frontal parietal networks. And again, our hope is just that by summarizing the data in this manner, we can really encourage others to test these theories in a more mechanistic framework. So we've also been looking into the specificity of these networks for predicting specific drugs across different brain states. So the data I've shown you up till now, we've identified a cocaine network and an opiate network that are pretty anatomically separable. However, one network was derived from reward task data, another from cognitive task data, and we haven't actually tested whether the opiate network also relates to cocaine use or vice versa. And we also haven't tested whether the relationship between network connectivity and substance use is in fact task dependent. In other words, whether or not connectivity findings hold across different brain states. So first we looked at the impact of brain state just on network identification. So we're just repeating our CPMs here. So when we repeat our CPM of opiate abstinence, this time using the reward data instead of the cognitive data, we find that we're only able to identify the opiate network using data from the cognitive task. Similarly, when we repeat the CPM for cocaine abstinence, we find that we're only able to identify the cocaine network using reward task data, really indicating that identification of both of these networks is very much brain state specific. However, next we wanted to test whether, once identified, relationships between networks and specific substances might generalize across brain states. So here on the left, we have the association between within treatment opiate use and connectivity within the cocaine network. And you can see that there's no significant association. So the cocaine network does not predict opiate use. And then on the right, we have the relationship between cocaine network connectivity and abstinence across different brain states. So for these analyses, we're just taking the cocaine network that was identified using the reward task, and we're using it to extract connectivity values during performance of a cognitive task and during resting state. And when we do that, we see that in both cases, we still see this modest linear relationship between connectivity within the cocaine network and subsequent abstinence over 12 weeks. So together, these data are indicating that while the cocaine network does not generalize to predict opiate use, the relationship between cocaine network connectivity and cocaine use does in fact generalize across different brain states. We see something very similar when we look at the opiate network. So on the left, you have the association between cocaine use and connectivity within the opiate network. And you can see that the opiate network does not predict cocaine use. And again, when we then just extract connectivity within the opiate network from different brain states, we find that the relationship between opiate network connectivity and opiate use does hold across different brain states. So opiate network does not predict cocaine use, but it does generalize across tasks. I don't want to overly belabor this point, so this is just to show you that we've run all possible combinations of this. So for example, we've looked at whether the opiate network connectivity during resting state relates to cocaine use, and in all cases, the specificity of these effects remains. So in other words, we're seeing a double dissociation such that the cocaine network connectivity is consistently unrelated to opiate use and vice versa. As with the cocaine data, we've also looked into the relationship between connectivity within the opiate network at post-treatment and subsequent opiate use at follow-up. And we again find a similar relationship between post-treatment connectivity and abstinence following treatment, potentially indicating some consistency of this relationship over time. And when we compare connectivity within the opiate network just from pre to post-treatment, we also don't see any significant changes, further suggesting possible stability of these effects, which is really interesting, and to me touches on this really important point, which is that networks contributing to treatment response may be distinct from those that change with treatment. or that are directly implicated in disease pathology. So for example, brain regions predictive of treatment responses in other disorders often have limited overlap with regions that consistently differentiate patients from controls. Another possibility is that brain regions that predict treatment outcomes may just be different from those that change with treatment. So at first that can seem counterintuitive, but within a clinical context, we know that factors that predict treatment, like motivation to change, are separate from those that change with treatment, such as acquisition of new skills. So the same may be true for neural networks. It's also possible that change within our abstinence networks may just take time to emerge and thus may only be detectable months later. That hypothesis is consistent with some data indicating that abstinence rates continue to improve following the end of treatment, following some behavioral treatments for cocaine use disorder. So it's reasonable that neural change might also take time to emerge. So we've begun trying to explore some of those possibilities. So first, this possibility that our networks are not only predictive of future substance use, but that they also just may be altered relative to healthy controls, and therefore potentially linked to addiction pathophysiology more generally. The theoretical basis that we're using for these analyses comes from a really nice paper by Hugh Garavan and colleagues from a couple of years ago, in which they basically just propose a couple different scenarios for what the brain might look like with prolonged abstinence in an individual with addiction. So here at the top, they propose that one scenario would be that recovery from addiction could involve some sort of restoration of premorbid brain function. In the middle, they propose that an alternative hypothesis could be that prolonged recovery may in fact require some sort of hyperfunctionality of brain regions involved in abstinence maintenance. So it's an elevation to above that observed in healthy controls. And finally, at the bottom, a third option would be that individuals in recovery from addiction just continue to exhibit decreased function, thereby conferring continued vulnerability. If we unpack that a bit more, based on this model, if we were to compare our abstinence networks to healthy controls, and we found that abstinent individuals had similar levels of network strength to controls, we might conclude that what we're seeing is this return to premorbid functioning. Alternatively, if we were to find that individuals who achieve abstinence have increased network strength relative to controls, we might conclude that we're seeing some sort of elevation of brain function or hyper-recovery. And finally, if what we found was that abstinent individuals had decreased network strengths relative to controls, we might interpret that as indicating a continued vulnerability for relapse. So to test these theories, we've computed connectomes from identical task data from 38 age and sex matched controls, and just compared this to our polysubstance using sample. Here I'm just showing you a binarization of the data I presented earlier, so this is nothing new. This is just to enable comparison with healthy controls. So on the left you have the abstinent individuals, and on the right you have the non-abstinent individuals. And what's interesting is that when we add healthy controls into this picture, what we find is that they're actually intermediary between treatment responders and non-responders, such that our treatment responders actually have increased cocaine network strength relative to controls, and our non-responders have decreased network strength. We again see a very similar pattern when we look at our opiate network. We find that our control group is again intermediary between responders and non-responders, with responders having increased network strength relative to controls, although the difference here between controls and non-responders isn't significant. But for both the cocaine and the opiate network, we're seeing this pattern that treatment responders have greater network strength relative to control participants, again consistent with this notion of an elevation of function relative to controls, or sort of hyperfunctionality needed to achieve abstinence. We're also super interested in this idea of protracted neural change following treatment, so the extent to which these networks might just need more time to adjust following treatment. Maybe we're just measuring at the wrong scale. So we've now collected multiple time point neuroimaging data from just over 50 individuals. So these individuals were scanned before treatment, after treatment, and then again 6 months later. The parent trial for this study was only just published, and so we've only just started analyzing the neuroimaging data. So we can't really answer this question yet. This is actually a really interesting data set as well, though, because it's actually composed of individuals with a range of different primary drugs of abuse, which is actually going to make our analyses a significant challenge, because the data I've been presenting thus far suggests that we really do have these dissociable neural substrates of different types of substance use behaviors, and so it may be that we're not going to be able to generate a single predictive model in this very mixed sample of individuals with different primary drugs of abuse. But our hope is that because about 20 to 30 of the individuals have primary cocaine dependence, we can still look at this idea of protracted neural change by looking at the 3 time points. Again, we haven't looked at that yet. I can tell you that if we just look at the baseline data during reward task, for those individuals that have a primary diagnosis of cocaine use disorder, and we look at our cocaine network, we can again replicate our original finding. This is a very small replication sample, but this is now the second external replication of these data, so which gives me confidence. So we're also really interested in looking into whether or not we can modify these networks. So we have a couple of different ongoing medication studies looking at whether or not certain medications are changing connectivity patterns within these networks. And we also just recently got funding to do a neurofeedback study where we're trying to train individuals with opiate use disorder to modify opiate network connectivity and see if that can lead to prolonged neural change and behavioral change, et cetera. So before I finish, and in full awareness that I stand between you and lunch, I just want to take a minute or two to discuss some considerations for clinical models and really to highlight the potential of some of these approaches to advance neurobiological understanding. So we've recently published a review that includes recommendations for best practices in addiction clinical modeling, but really many of the issues apply to any sort of clinical modeling of neuroimaging data. This is just a schematic diagram of typical steps that I'll use to highlight a few key points. One of which is really the importance of defining your question of interest, and most importantly, your definition of treatment response. And just to point out that this will, of course, have significant implications for both algorithm selection and model evaluation. And I'm happy to talk more about that if people have questions. When it comes to model evaluation, it's important to remember that the best metric will always depend on your question of interest. So just as an example, here we have confusion matrices for models with high sensitivity and low specificity on the left, and low sensitivity and high specificity on the right. And then we have two separate scenarios at the top and at the bottom. So at the top, we have assignment to active treatment, and at the bottom, we have termination of active treatment. And for both scenarios, the cells in red are corresponding to individuals at increased risk for an overdose. So we can see that for outcome 1, overdose risk is really minimized when sensitivity is maximized, but for outcome 2, overdose risk is minimized when specificity is maximized. So assuming that the overall goal of addiction treatment at a minimum is harm reduction, then a model with high sensitivity but low specificity might be acceptable for prediction of medication treatment initiation, but it might not be optimal for predicting termination of treatment and vice versa. Obviously, an ideal model has both high sensitivity and high specificity, but very often there can be a trade-off in maximizing those two things. When doing clinical prediction, it's also really important to carefully consider the window of assessment. So while scanning prior to any sort of clinical intervention is often considered desirable, scanning during that time can introduce a lot of unnecessary confounds. In the case of addictions, we have effects of acute intoxication or withdrawal. In the case of other disorders, we have effects of mood state or psychosis state. In addition, scanning prior to clinical intervention often isn't feasible unless you're delaying treatment initiation, which places unnecessary burden on the participant, and again, really isn't practical in terms of what would eventually happen in the real clinical world. So although scanning, early on in treatment instead of before treatment may pose a little bit of a challenge to mechanistic understanding, in many ways it may be the best option. And so long as you're clear about what it is you're looking at, it's okay to scan once they're already in treatment, in my opinion. So I'm not going to say much about different cross-validation strategies today, but again, I'm happy to talk about that if people are interested. But I just want to point out that your sample size will influence your selection of your validation strategy. So all of the models I've presented today were initially generated using a leave one out scheme, which is somewhat controversial. There's been a fair amount of pushback against using leave one out cross-validation and also just against small sample sizes, meaning anything less than 100 or even 200. Recently, there's been a couple of review papers about this. And there are good reasons for that pushback. However, I would argue that leave one out really is your best validation approach for a small heterogeneous clinical data set. It lets you leverage all available data for model generation, and it also avoids the need to balance for other variables like treatment assignment across folds, which you would need to do if you're doing like a 5-fold or a 10-fold. Of course, we do know that leave one out can overfit the data more than some other internal validation approaches. I mean, everything is prone to overfitting. So one practical solution is just to use all available data for model generation and then to combine that with some sort of external validation, which is what we did with the cocaine networks. If you have a small sample size and you don't have access to an external validation sample, I think you could still use a leave one out scheme, and you just make your model and your code publicly available, and you're encouraging others to try to replicate or reject your model. And that's really going to be the fastest way to get our models to the places that they need to be. Finally, to my mind, it's really essential to conduct post-hoc testing to provide elucidation of mechanism, as without this, findings from even the most highly accurate models will do little to advance our neurobiological understanding, which is really what we need to develop new treatments. So again, very briefly, when we talk about mechanism, I just want to point out it's important to consider your model findings across multiple levels of interpretation, with the most basic level being the connections themselves, and the most abstract level being the sort of overarching neurobiological model, which can be used to guide treatment development and act as a basis for future testing. Just to give an example of what I'm talking about, this is an incredibly basic example of a support vector classification approach in which we select some sort of a priori regions of interest, hopefully based on the literature. We put it into our SVM, and then we assess the performance of our model. And while interesting, I would argue that just stopping there actually doesn't do all that much to advance our neurobiological understanding. We really need to combine it with post-hoc testing. Because like in this context, interpretation of model results really is not as simple as assuming that the largest weightings are the most significant features. So one like incredibly simple way that we can start to get at interpretability is to simply rerun our model, excluding different features, right? So we can leave out one individual feature, so let's leave out like amygdala volume to get at whether or not we even need the amygdala to have our model be predictive. Or similarly, you can leave out everything except the amygdala and see what is the predictive value of that alone. And hopefully using those results, you can then generate a better mechanistic understanding which you can use to update your theoretical model. Again, this is a very, very simple thing to do, but a lot of people don't do it. So this is just, and there's fancier ways to get at this stuff. People call this virtual lesioning to make it sound fancy. But yeah, so this is just like my big reminder that elucidation should also be a goal of prediction. And so with that, I want to thank everyone for listening, and my key collaborators, and NIDA, and all the funders. Thanks.